So, Ollie's staying on stage, and Ollie's going to talk to us now about NHS England and the secure data environment. This is one of the things that when we were last at the National Directors meeting, they said any case studies you've got about the secure data environment would be really helpful. And when I said that to Ollie, he said that would be good if they decided what it was or something like that. So Ollie's going to tell us all about it.
Well, thanks, Mark. I should say I'm not going to tell you all about it. We've got Jim Hughes here, who is the Senior Responsible Officer for Cheshire and Merseyside Data Interaction Programme. And he's going to come and talk about what the SDE is, how we can get involved in it. And I think Sarah's going to have a little cameo in this as well. So I will pass straight over to Jim.
Good afternoon, everyone. Quite a strange way to start a presentation, to know in advance what the questions are. But nevertheless, not daunting. Yeah, I just spent the next 20 minutes with and a little bit of time from Sarah to talk about the secure data environment for the Northwest, which is a program in train. So it started about a year ago in development. Just to begin, what trying to achieve in the next 20 minutes and through the panel is so you can have some awareness of what the secure data environment program is and what it will provide for data and research, what provide for research. To explain how the public and patients can help co-create and get involved. And I just, for the avoidance of doubt, and you probably know this, so when I say public and patients, there's one thing we have in common. We're all the public and we're all patients. So it's addressed to everyone in the room. And also, I guess for me to understand and take back some key opinions, hopes and concerns. And some of that work has already begun because I was part of a forum with some of the people in this room talking about how the NHS uses its data. So why is it that we need to change what we're doing? And more importantly, why does health and care data matter? Well, and this may seem obvious, but it is quite the envy of very many places, many other countries in the world, that the information collected through our health and care organisations does help to improve individual care, direct care, speed up diagnosis, plan local services, and importantly get used for research into new treatments, therapies, and the like. And I guess, and I'll say a little bit more about this later when we look at some very specific examples. One of the stark examples in terms of from the COVID-19 pandemic was very much that data saves lives in a very meaningful way, and that's got to stay as critical to our understanding. So why are we doing this now? Well, there's the cynical view. Well, the government decided to put £200 million into it, so that was a really good plan, and it went into research and development for the use of data for research and development, and the intention of that was to move away from processes relying on data sharing, which was largely about shared care records and such like that you may be aware of, and more into a model of data access. How do we get access? How do researchers, particularly, but also those doing planning and population health, get access to data? And the idea is to build a network of secure data environments, and one of which across nationally, and one of which is in the Northwest, which is a collaboration between the three integrated care boards, Greater Manchester, Cheshire, Mersey, Langston, South Cumbria. And a piece from the review that presses about this is that we've got 73 years of NHS patient records, more recently most of it digitally recorded, and they represent deeply buried treasure that can help prevent suffering and death. It says around the planet, but I think what you have to think about when you read this is a bit, so what's in this for me? We quite freely give data away to many of us perhaps, to platforms like Facebook and Instagram and such like, which is a treasure trove for industry. But here's a treasure trove that we have, which is a public asset. And that's really important. So it's our collective duty to make this work. So I mentioned past successes, and two stories, both in the news. When the army came to Liverpool, I always say, and in brackets, for the right reasons. And I'm not sure why I say that, but why the army came to Liverpool anyway, and conducted rapid antigen testing, asymptomatic testing. And the key thing about that, well, I would say this, right, because I had set up the data stores for this. The key thing about this was we were able to process the testing data within 30 minutes. And therefore we were able to say to the sites that were setting up, that the army was setting up in different parts of Liverpool, at the end of a day, change the site from one part of Liverpool, go to that part of Liverpool, because that's where the infections are. Okay, so really powerful use of data, and yes, it did reduce infections and it did save lives, and the impact was that this became policy around what we now know as lateral flow testing, which just became a common usage post this. And the other was about the reopening of events, and again, in the news at the time, in May 2021, big event in Sefton Park, mask-free for the first time, those kinds of events. Real-time data linked to ticketing and testing and contact tracing far outweighed the benefit that was in other national events, like the Crucible Theatre and Wembley was another example. But the work in Liverpool showed the impact, the power of the data. So a little bit about the secure data environment itself. That's why we do it. Where does the data come from? It's a mix of patient-level linked data sets. Ollie referred to some of this before, from GP practices, primary care, community, mental health, acute trusts, and also some national data sources into a secure data environment. And basically they are, it is, but they are across the country, data and research analysis platforms, de-identified data, nobody can be identified from them, and approved researchers will be able to use the tools to analyze that data on the platform without the data being moved or copied. The data stays in the secure data environment, and I'm just preempting a potential question later on. None of this data flows into some national pot of something, right? This is secured within Cheshire and Merseyside, or within Lancashire or within Greater Manchester. And there's processes in place to control who can be used and what we can do. Helps to standardise research practices, and I guess three messages in terms of the way that they're being established, to improve patient privacy, to improve security in terms of where the data sits and who has access to it, and the efficiency of researchers being able to get access to bigger data sets and having a bigger impact in terms of the reach. So I'll take it back a slide. So I'll just pass on to Sarah just to talk a little bit about more of an example in terms of the health equity benefits.
Right, good afternoon everyone. I should say that I'm going to talk about a project in particular to illustrate how we can use the secure data environment. And I've worked on these data in another region of the UK, and I think it's about time that England caught up, and so the investment from NHS England is very timely after we've shown what we can do with data in COVID. And so a particular project that I've done is to look at 9,000 tenants who were housed in social housing, who had their homes improved to reach a decent housing quality standard. And we followed these people for a whole decade, and we could do this because we had the routinely collected data, and the council gave us data on the month that they updated the kitchens and the bathrooms and the heating, etc., to bring the houses up to a decent quality standard. And what we showed after we followed them up for a whole decade was that there was a 40% reduction in emergency admissions for cardiovascular, respiratory and injuries for the older tenants in those homes. And we couldn't have done this any other way, because if we'd surveyed them, we would have only got the little old ladies at home. We would have created bias in the data, because we had everybody through the routine data and we could link it to their housing. We could actually prove that there was this massive reduction in emergency admissions. And we looked at the health equity, obviously, as well, and we saw in this and another project that the benefits were greater for those who are living in more deprived regions. And I guess what we want to do with the secure data environment is that we've got systems in the Northwest already, but they're a little bit clunky, shall I say. I don't think anybody would mind me saying that. And as Jim was saying, we need to make them a bit more efficient. So if you go on to the next slide, please. I can't remember quite what's coming next. Yes, so this is a this is a slide that talks about what we could do in the Northwest using the Centre for Healthy Climate Futures, and we can use expertly curated big data sets to evaluate the impact of our social and environments on our health, like that housing project. But we'd also like to use the new Northwest secure data environment to help us evaluate the impact of extreme weather events, so flooding and heat events, on people's health service use. So this is now and into the future. So we know now that we have one heat event every 4 years, but these are expected to increase, so we've got 4 every year. And that will result in more people becoming sick and needing hospital admissions. So we're interested in hearing about what you think about this project. We have submitted this for funding, but we'd like to hear whether we should do this and how we should do it to involve the public, and how we can link the health data into the secure data environment to data provided by the Met Office, for example. So we'd like to access all the data anonymously, like Jim said. It's all the identifiers, the names and addresses are removed, and we want to be able to predict the healthcare utilisation due to likely different climate scenarios, and work with the public on creating solutions, so we're not subjecting our poorest, who are likely to be hardest hit by these climate changes. So let me know, please come and talk to me and let me know what you think about that, or in the panel, or generally afterwards. And if I could have the next slide, please. We've also submitted another proposal to a major UK funder, and in this one our our vision is for having a step change in understanding how best to harness the power of local urban places as tools for population health. So you heard before about the EPIC theme, who are place-based, but I guess we're looking at the entire region and all 3 million people all in our region, all in the one go. So we want to show how and why local environments impact population health, and how easy it is to make place-based changes in the north of England. So we're going to be using the new birth cohort in Liverpool, the children growing up in Liverpool, that's currently recruiting. So if you know anyone in the early stages of a pregnancy who's been cared for at the Liverpool Women's, then please ask them to get in touch. That's a plug for that programme. But in the Healthy Urban Places North programme, what we want to do is look at our 10,000 families in our birth cohort, and we're looking at them in the city to see if they can see how their health is changing and how their city is changing and how this impacts on the health. And we can do that through a system that is organised more efficiently, like the Northwest Secure Data Environment. And I think that's it from me, and I'll pass back to Jim to finish up.
Thank you. So, just to conclude and to cover two important areas, one is around data security and the other one is around public-patient involvement. But certainly to start with data security, there are nationally established 5 safes that are applied and must be adhered to for all of the data that is stored. It has to be safe. The projects have to be safe themselves and approved by data owners and for the public good. Researchers have to be safe people. I mean, looking around the room, I think pretty much I'm okay with the people around. But they have to be trained and authorised to use data safely in a safe setting. And interestingly, we just opened through the University of Liverpool the Civic Health Innovation Labs, and there's a secure data room in there. So for access to data, you have to be locked within the room without your mobile phone, and just to be able to secure the data. We need to think about the physical protections that we put in place as well as some of the automatic, and we have to produce safe outputs. Similarly, we have to apply controls, organisational sharing agreements. We have to obey UK. We have to obey UK law, and approved researchers can only get access to what they need within an airlock type system. And I'm just conscious of time, so I'll just also say the other thing that we have in place is a data access and asset group, which has all of the right people on it to ensure that the rules are being, like scrutiny group to make sure the rules are being met. Really importantly, includes the public voice and public representation, and required ethics approval. So just a final slide. As we set this up, and it has the potential to be a difficult ask because we're bringing together a lot of data, and it has a potential to be a difficult ask because we're at a time when there's quite a lot of noise in the system around a recent national procurement, which isn't this, but it sounds a bit like it, which is unfortunate. But so what is it that we'd want from, what will secure data environment do in terms of public involvement? We've already started organising public forums, focus groups, citizen juries and the like. Public representation through our governance, transparent to the public. And I guess what can you do? Attend the public events, be heard, and co-produce, as we're in the just through the first year of this, co-produce this with us in order that we can get the right governance and attend to the public voice. And that will be a really important part. So I think we're going to move on to a panel now. Thank you.
Thank you very much. That was fantastic. And if I may, I'm going to start that off, if that questions. So, first of all, I'd like to welcome members of the ARC and offer the ARC to support that work that you're doing and to input into that public involvement. We have over 100 public advisors in our forum registered. We have a system, we have a process. So we're more than happy to help input into those approaches and also to give some advice on to really how to engage the public voice in different ways in different settings. That's more, we're not about somebody coming and telling us what we're going to do and say, is that all right? Or as you know, you've met us, so you realise that's not what we do. So that's the first point. The second point is I'm also a practicing general practitioner and I've been sitting on the local medical committees for about 30 years. And in recent years, there's been a number of waves of government proposals, mainly since 2010, of how they want to collect and use general practice data, and we've always pushed back on it, because it's never been clear that it's had the assurances that you've told us about today, which is great to hear, but I'm worried that if the national one keeps throwing up around this of a different way that those data are going to be used and trawled for NHS England or other purposes. There was talk, for example, that the Home Office would have access to it, that HMRC might have access to it, and so lots of people very reluctant about saying, well, hang on, if we do that, people won't register with a GP because they won't want their data shared by a whole range of different agencies.
Yeah.
So there are some real big tick reassurances that the public and the professionals will need that you have less control over, but I wondered if what you knew about where we're up to with those other proposals of, that's great, but those same data, which you're going to handle fantastically and securely and with ethics and everything else, another part of government may say, well, thanks for those data, we're going to use them in a different way.
Yeah, so and it's a really important point. So what we're talking about in terms of the secure data environment, as you correctly made the distinction, Mark, between the data that we'd be holding in each of the areas under, and they all have under the data controllership, predominantly of general practice, and with the trust of general practice. So that's important. That's the secure data environment. The most recent procurement around a federated data platform has a number of associations, not all of which are planned or necessarily come true. So one of the key things about the federated data platform is that no data will flow from the secure data environment nationally into some other data set, because that would be a breach not only of the trust but of the law in terms of what we set up. And we're very fortunate in Greater Manchester, Cheshire Mersey, and in Aspiration, but following the same path, Lancashire and South Cumbria, to have that data secured for each of those individual areas. I think, but I recognise the concern, because there is a sense in which the government, say, or a government department could make a, I don't know, pass a law, make a command. All I would say at that point is that each individual person, and indeed each individual data controller, could withdraw their data at that point.
So this is the key question I had. So at the moment, I think it's opt-in or opt-out. Is there any intention that you know of that you could say, I'm opted in for the secure data environment, but I'm opted out of the national one?
I'm not aware that you can. So the national federated data platform is based on a direct care use case, predominantly. So in the first instance, in the sense that you can't opt out of direct care. For the secure data environment, what we're setting up is project by project, an individual could opt out. If we have an instance where we think that project is a product of the FDP, you could opt out of that product. Say if it was within the Royal or within Aintree or and I'm sorry, I'm using Cheshire Mersey example, East Lancs. You could opt out of that as a project. But there isn't as yet a national opt-out for the federated data platform in that sense, because it is being put forward as supporting direct, which it is at the moment. All the products support direct care. So, but these are necessary questions to absolutely flesh out. And what we have is a responsibility within each of the areas, and certainly within Cheshire Merseyside that I represent, and I'm sure it's true for the other areas, to work with our data controllers to undertake what it is that we will and will not allow, and what we will push back at if nationally somebody is looking to use data and it doesn't follow our agreed established guidelines with the data controllers. That is an absolute key. From COVID, what I know from COVID is that we only were able to store the data, not because we got the data from GP practices, but because we established the trust. It's only about trust. It's not really about the rules, but you have to have the rules. But if you break the trust, you lose everything. And that's a strong lesson learned for me through that period. It may not be an assurance, may only be assurance for this part of the world in the northwest, but all I can give you is that assurance from a Cheshire Merseyside perspective. Question here.
Yeah, I'd certainly echo that. The civic approach and trust is absolutely key, isn't it? I was going to be a bit more parochial in my questions, though. So as a researcher, any idea what the process is going to be to apply for access to the data, and then any thoughts about what the costs are going to be? Because at the moment we pay NHS Digital an outrageous amount of money to get our own money back, our own data back, and so what's the plan?
Sorry, what was the first part? The second part of the question was the commercial model. What was the first? Sorry, first part was access. Okay. So the proposal is that there'll be a single access process coordinated through the HDR UK, who do very similar work at the moment. That will be adopted through through the Northwest Secure Data Environment, but actually probably through each of the individual areas. So Cheshire, Mersey, Greater Manchester will adopt that approach. So you can apply for access to the data, and it will very much follow the position that I put around the data access groups that were established to look at the application in order to ensure that that it appropriately meets all of the standards and all of the tests for law and has public representation in it. So data access will be dealt with. The difficulty is the commercial model, and that's still being worked up. All I can say about that is that there are a number of ways that it's being described. One is that you'd be familiar with a subscription model to academic institutions. Another is a project-by-project basis. I think it's very, very unlikely it will be on the basis of volume of data. It's much more likely to be on the consumption of data because all of the costs are the storage in the cloud. So it's much more likely to be based upon the storage in the cloud if it goes to that model rather than the volume of the data. So it's the amount of processing you do and the amount of storage, the amount of the cloud that you consume in that sense. Sorry, that's quite a technical answer, wasn't it? Apologies. Someone said I was a data expert. So go with the flow. Sorry, any other questions? So we have a question. We had a question earlier.
No, I was just holding the mic.
Oh, there we go.
Thanks. Are there any missing data sets that the ICBs don't have that you'd need a hand with getting? Is there anything that the ARCs could help with?
Well, the answer to that is yes. There's a lot, and is it data the ARC can help with? I think some missing data sets at the moment. Predominantly what's stored is structured data. Interestingly, although we have a mental health research innovation centre within Merseycare in Cheshire Merseyside, a lot of the mental health data, the richness is in the unstructured data, the written data. So that's not yet within the SDE. There's a lot of work, particularly around the health determinants data, the data from local authorities on housing, education, so forth, and the kind of support, the kind of work that Sarah was talking about. There's also genomics data, and you know, the more that you talk about the data that isn't available, the more you realise the data that we have got available, whilst huge and rich, is actually quite a small subset of what we wish we could have. In terms of the ARCs, in terms of the ARC supporting that, I think some of it is about lobbying and being part of the secure data environment and prioritising. I think there's another really important part that was talked about, Mark mentioned before, in terms of public advisors. There's a really big voice that if the public say this is the kind of data that we would expect to see, then that matters. It matters when the public collectively raise a voice and say this is what we would like to see in our research, access for our research projects. And I think that mustn't be underestimated. It's a really good point that was made about don't come to us and just tell us what you're doing. Come to us because we're co-producing. And I think that's a key thing. That means the voice is heard.
Hi, I'm a public advisor with the ARC, and I also work with the. I'm on the board of the thing called the Transforming Care for people with learning disability and or autism with the ICB. And you keep talking about, you know, co-production, etc., etc. And I learned about co-production when I was working on that, to be honest, the Transforming Care. I've never heard of the SDE till today. If you were to, you say, you know, members of the public will demand this or want that. No, they won't, because they've never heard of you. So how do you do this co-production? Who are you involving? How many people are you involving? How do you get them, you know, invite them to be involved, etc., etc.?
Yeah, so as a process, it has to start somewhere, and there has to be a time that it starts. So this is the third event. We're trying to raise awareness around what as we develop the secure data environment, raise the awareness with organisations like this and with members of the public. We're starting a series of forums across the Northwest. There's just been appointed a PPIE lead within the Northwest within the last 2 weeks. A significant budget attached to that work in order to do the deliberative of the engaged events, and also there will be public engagement around the use of data and a secure data environment in each of the ICBs over the next year. So, so the reason you haven't heard about it is because it hasn't really been much publicised. but this event is one of those that starts that off. And so what does co-production mean? So you say you learned about co-production, you work with learning disabilities. My background, and I'm still employed by Merseycare Mental Health Trust, have been since, I don't know, 2012. And within that field, everything is co-produced, as in we have service users on interview panels, we have service users designing services, we have service users with data.
Just before you go on, I'm a governor of Merseycare as well, so...
Okay, so you'll be aware of all of this activity then. So, yeah, so, well, great. So I think when you're in that environment, then you understand that it isn't just words. It's not just a way of describing some other passive set of activities. It's actually a way of formally and properly engaging with the public in the design of what we do.
Hiya, can I just follow on from Alan? I'm also a public advisor,
Yeah.
and I'm involved in other areas where we're trying to recruit public advisors. Now, we're a captive audience to public advisors here because we're quite heavily engaged.
Yeah.
And you say you're going to these, putting these forums, you're going to these places, but again, won't that be with people that are actively or want to be engaged? And how are you going to get involved with the communities that aren't involved? That aren't actually understanding what data is, aware of what data is about, have this negative assessments of data. So it's the underused communities.
It's an excellent question, and this might sound a little bit processy, but this engagement work starts with an equality impact assessment to understand, and the one for Cheshire Merseyside completes on Friday, where we look at the population and we identify those groups that are most likely to be affected, those groups who are in effect the hardest to reach, rather than an audience like we have here today. And then we build our events and the way that we do things, so not just saying, oh, it's, because you can't just say it's an online event. You have to go to where people are. So within the Civic Data Cooperative, within the University of Liverpool, doing this kind of work, they've done some really almost like door-to-door type work, the project in Halton, to reach the groups of people that are relevant to the work that they were undertaking. And it's that approach. So we do the work to understand where we need to get to, and then we target our activities, and we design our activities to meet those needs. That's how we do it.